So, just to give everybody some background, I started this organization in honor of my amazing son, Theo, who died last February at the age of 17 from leptomeningeal cancer. I wanted to make sure we had resources for people, educational information that I felt like I was not able to find when he was diagnosed. And in terms of radiation, he had targeted radiation at the age of 14. He then had proton spinal radiation at the age of 15, and finally whole brain radiation at the age of 16. So we went through a lot of different versions at different centers, and there were always so many questions. But you're also moving so quickly, you don't often have time to figure out the resources and even know what questions you have. That's how I felt. So today, hopefully, we are going to try to answer all those questions, the ones you have and the ones you didn't think of that other people may have. So now it is my great pleasure to introduce our amazing presenters, two leaders in the field of radiation oncology. So first we have Dr. Jonah Hadangadi Gluth. She is a radiation oncologist who specializes in treating primary and metastatic brain tumors, as well as breast cancer. She is chief of the Central Nervous System Tumor Service, a co-leader of the Central Nervous System Disease Team at Morris Cancer Center, a professor of UC San Diego School of Medicine, and the associate director of the Center for Precision Radiation Medicine. She also is actively involved in research to improve the efficacy and safety of radiation therapy for brain tumors. Welcome, Dr. Hanan Gadi Gluth. We also have with us Dr. Jonathan Yang. Dr. Yang is a radiation oncologist at NYU Langone in New York City. He is an associate professor at NYU School of Medicine Department of Radiation Oncology, the co-director of the Brain and Spine Tumor Center, and the vice chair of research. Dr. Yang has been passionate in advancing the treatment of patients with leptomeningeal disease. He serves as the principal investigator of several ongoing first-in-human trials to guide appropriate treatment selection in patients. Welcome, Dr. Yang. So we're going to just dive right into questions. We're not going to do presentations today. We want this to be kind of a formal, informal discussion and chat so that we can really get to all the questions that people have been asking. So first, Dr. Hadangadi Gluth, would you like to start with how radiation works, just in general terms, and what are the different ways radiation can be delivered?
So, radiation is essentially can come in different essentially forms of energy, but essentially it's a non-invasive way where a beam of energy or multiple beamlets of energy are aimed at the body to treat a particular area with the purpose of either eradicating tumor, helping decrease tumor cells, kill tumor cells, and delivered in a way to help avoid or preserve normal tissue in that region. And one of the reasons it's particularly used in brain and spine tumors is, and especially with leptomeningeal cancer, is that with systemic therapies, they don't cross the blood-brain barrier very well, but radiation therapy is excellent at getting past any barrier, essentially. So whatever we want to treat, we're able to treat with radiation.
Thank you. Dr. Yang, we often hear about targeted radiation or radiosurgery, and then we hear about whole brain or spine radiation, as I was saying that Theo had, and also craniospinal radiation. So can you explain how each of these works and why you might choose one versus the other for a patient with leptomeningeal disease?
Yeah, that's a great question. So stereotactic radiosurgery or targeted radiation really is for us to use very pinpoint, very small beams of radiation to treat specific parts, quite often in the brain. And these targets tend to be small. For example, a small brain metastasis that we want to eradicate, we often use this technique to focus the radiation on that brain metastasis. The other forms of radiation that you mentioned, such as whole brain radiation or treating part of the spine, these are tend to call involved field radiation, meaning that we're treating part of the CNS, the brain, or specific parts of the spine, but we're not treating the entire CNS compartment. Craniospinal radiation, on the other hand, treats the entire CNS compartment, which means we treat the entire brain, entire spine, as well as the CSF that circulates around the brain and spine. So the way that I think about when do we use what tool really is based on the intent of the treatment. If the intent is to try to eradicate as many tumor cells as possible in the entire CNS space, including the fluid, then the tool to do that is the craniospinal radiation because it covers the entire area that needs to be treated. If the intent is to treat specific parts of the brain or spine that's causing symptoms or to prevent symptoms from happening, then involved field radiation would be a very useful tool in that scenario. In fact, involved field radiation is the most common form of radiation we use for leptomeningeal metastasis. And when we are treating a specific target that is smaller and maybe in a critical area to prevent obstruction, for example, in the brain, then stereotactic radiosurgery can be considered for those scenarios as well.
So that's really helpful to understand the different types. Now, what about photon versus proton? And maybe Dr. Haddon-Gattagluth, can you take this, the difference between those two types and how that fits in with the craniospinal and the targeted and all of that?
Sure. So, photons are X-rays. They're much more commonly available throughout the world, and they can be modulated with different mechanisms to make it either very focused radiation, like the radiosurgery that Dr. Yang described, involved field, which is a slightly larger, and even craniospinal. There's different ways. We've had photon radiation for a very long time, so there's lots of different and more modern techniques to deliver photon radiation, either in a very focused way or in larger regions of the body. But because the particle itself, the X-rays, can travel a little bit beyond when it's delivered to tissue, there's some limitations on sort of how much normal tissue sparing you can achieve with photon radiation when you're delivering something as a large field like craniospinal, where you're treating the whole brain and spine together. Proton radiation, proton's a charged particle. It's a completely different sort of treatment. It's still radiation and it's still non-invasive, but it's delivered at a special center. They have to have a special proton cyclotron. It's very complex. There's not that many of these facilities, and it depends on the state you're in and the region of the United States or other countries. So it's not as widely available. It's more complex. It takes a little bit longer to plan. And we do use proton therapy to treat brain tumors, craniospinal radiation when it's appropriate, in children, in young adults, and older adults as well. So they're essentially two different therapies, and typically your radiation oncologist would be able to explain the difference between them or when one would be indicated over another.
Well, that leads perfectly into my next question, Dr. Yang. I was going to ask, when you're making a treatment plan, what does it entail, and how do you make those decisions of proton versus photon or craniospinal? You did explain more the craniospinal and that piece, but the proton, photon, and really figuring out what that treatment looks like for people.
Yeah, no, and that's again a really great question. I think as any radiation oncologist, these type of decisions are made jointly with our patients and quite often with patients' family at the same time as well. Understanding, the risk of benefit of each approach. But to, very quickly simplify what we think about when we encounter a scenario that we may provide treatment, the first question is always, is radiation an appropriate tool here? And for leptomeningeal metastasis, radiation really has been a very important cornerstone of treatment for the reason that Dr. Haddon-Gattagluth had already mentioned. And then the next question becomes, what is our intent of radiation? If the intent is again to palliate, to focus on specific part of the brain or the spine, then involve your radiation with photon, which is the most accessible form of treatment, it's more than appropriate, and it would also be able to allow us to start treatment relatively quickly. If the intent is to treat the entire craniospinal axis, then we have to decide what tool do we have in our toolbox to achieve that safely and efficaciously. And this becomes a question of, do we use proton craniospinal radiation or do we use photon, more sophisticated VMAT photon-based craniospinal radiation? And the difference in those is that as Jonah already mentioned, they're both radiation treatment, and they are, in terms of efficacy wise, we wouldn't necessarily think that there would be a difference. But the way that they're delivered is different. Proton radiation again require a specialized center, and it quite often uh, may result in patient travel a long distance to get there. That may not be practical based on their disease status or how they're feeling. They would, and I often do this. I encourage patients to be as close to their family as possible because they often need support throughout the process. If they are, if a patient is close to a proton center, this is an easier discussion. But if they're not, and the facility has the ability to deliver VMAT-based photon craniospinal radiation, that's sometimes considered with their radiation oncologist. I would say that there are about 55, I want to say, or if a little bit more than that, proton center in this country, and rapidly growing. I think in the next few years, proton therapy will probably become much more available, and this will be a lesser dilemma in terms of getting patients to those centers. But in the meanwhile, I think that we have to utilize the tool that's available to us based on the clinical scenario. And quite often that may not be protons, and that could be a photon-based treatment.
So just so everybody knows, we also have a link on our website to the proton centers around the country, so it could help you find one if you're looking for one. I just wanted to go back to one thing you said, Dr. Yang. When you say using radiation therapy to palliate, can you explain what that means, just to make sure everyone understands that
Yeah,
term?
so palliation means that quite often is, let's say a patient with leptomeningeal metastasis presenting with headaches from the diseases that's surrounding the brain, that's irritating the meninges and causing these headache. Radiation does a pretty good job in terms of being able to relieve some of these symptoms, and more importantly, stabilize the patient so the patient doesn't continue to have neurologic decline. Radiation is, again, as Dr. Hadangaiglou had mentioned, is the fastest and the most direct way to deliver therapy to the CNS. And quite, again, that's the main reason that we often rely on it for the treatment of leptomeningeal metastasis, because these symptoms can be unpredictable and they can come on quickly and needs to be stabilized quickly.
Thank you. That's helpful. So what about Dr. Hattengadi-Gluth, the perspective from the patient? What did they experience? What can they expect during treatment, like the actual treatment process for them? What does that feel like or look like for them from what you know?
So again, it would sort of depend on what their radiation oncologist recommends. But typically, a patient would come in and visit with their radiation oncologist, who would then evaluate their imaging, their lab finding, maybe their results from their cerebrospinal fluid, any additional tests, imaging of their brain and spine, and as well as, like what Dr. Yang was speaking about, their symptoms, and do a good neurologic exam to find out, how the patient's doing and what their goals of care are. And then they would make a treatment recommendation in that context, either for very focused radiation, a larger field of radiation, or even potentially craniospinal radiation. potentially enrollment on a clinical trial if that's indicated or available for them. And then they would walk you through the patient with the sort of side effects and what to expect, and that's typically called a consent form, and the patient would sign that, just saying that they discussed the side effects and potential benefits and potential sequelae or possible things that could happen in the short term and the long term. And then after that's happened, typically the radiation oncologist would essentially submit orders to then do that treatment, which typically goes through an insurance process, and every insurance carrier is slightly different how quickly these are approved. Most of the time we make these requests to the insurance company stat, so we're usually, the window of intervention with leptomeningeal cancer, as many of you know, is very short. So we typically want to be able to start treatment very quickly. So we would submit those orders, and that would get approved by the insurance company, and then they would book essentially a mapping session or a CT simulation. It's called different things, but it's essentially a tool for how the radiation oncologist and their team would map the radiation to the patient's body, because everything with radiation is individualized. Unlike a drug where you might get a pill and it's the same pill anybody would get, but just a different dose. Radiation is completely individualized to that patient's body, their anatomy, their type of tumor. So the mapping session is really imperative for that purpose. And then when the patients, during the mapping session, they would have typically a mask made, invariably to hold the head in place. Sometimes the mask will go over the whole head. Sometimes it's just sort of like the forehead and the chin. Sometimes it may cover a little bit of the neck and the shoulders even. It kind of depends on what exactly they're treating, and the institution might have a slightly different mask. And then with that mask that's made, which is essentially just made out of like a thermoplastic mesh, kind of like plastic, and it has holes in it, and they make it warm in a water bath, and then it stretches over the face and head, and they let it dry for a few minutes, and then they take a CT scan either of the whole head or the whole head and then the whole body if you're treating the whole spine as well for craniospinal radiation. And then they'll do potentially some little marks on the mask, and then they'll take that mask off, and then the patient goes home. So typically that whole appointment is about maybe 30 minutes. We typically don't give any IV contrast during that appointment. Maybe some institutions might, some radiation oncologists may recommend contrast during the CT portion of that. And then the radiation oncology team would then, led by typically the doctor who met with the patient, would then use that imaging as well as all the other things that we talked about and the patient's exam and things like that to define what they're going to treat, whether it's the whole brain or a portion of the brain or a portion of the spine or the whole brain and spine together. And that would then be planned by, there's sort of many different facets of the radiation oncology team. There's dosimetrists who actually help do the planning after the radiation oncologist has actually delineated what they want to treat and what they want to not treat and avoid. And then there's physicists who are involved with making sure the plan is safe and deliverable by the machine that the patient will be treated on. And then that plan goes through quality assurance checks, and there's typically a whole process and workflow that's happening while the patient's at home, and so you're not there for any of that part. This is typically happening behind the scenes. And then they would give you a date and time to come in for your first treatment. So all of that's happening, and then sometimes patients ask, why can't I start right now? Or sometimes patients will walk in and say, am I getting my radiation today? And I say, well, no, we're talking about the treatment today, and then we have to go through a bunch of steps, actually. So as opposed to other therapies like, oncology, where they're putting an order in a system and somebody will dispense a pill and they swallow that pill, or potentially ordering an infusion and you go to an infusion center and get hooked up for the infusion, the radiation actually is individually planned, so it does take some time. And then the actual experience, the patient would then come in and they would get called to the machine. They would typically then have the patient lie down with that same mask they made during the simulation process. Then they take some images to make sure that the setup is correct and potentially correct any setup. For example, if the head is slightly rotated, they would want to correct that. They also have ways to correct the patient's position just by using the machine itself. So the typically they call it the couch. It's like kind of like the bed that you're lying on can rotate and move around to adjust for any anything in terms of where the position is relative to the mapping position. And once they determine that everything is set up accurately, then they essentially, there's radiation therapists that are actually going to be the ones getting the patient into the room, set up, and delivering the treatment. It's not typically the doctor. These are therapists who are experts in delivering radiation therapy. The same way, for example, if you get a mammogram, it's not the radiologist that's doing your mammogram, it's typically a therapist who's doing the mammogram. So just like that, the therapists actually deliver the treatment, and the treatment itself could be delivered as quickly as a few minutes. Sometimes it can take 10 minutes, sometimes it can take 20 to 30. It sort of depends on, again, as Dr. Yang described, what we're treating, how big of an area, how many treatment beams and fields, if there's any issues with treatment setup. But typically the appointment lasts about 30 minutes, maybe a little bit longer, and then they take the mask off and the patient goes home. So it's typically a pretty fast once the patient gets used to it, and then it's repeated typically every day or every weekday. We typically treat 5 days a week at most places, and so the appointment becomes pretty routine. And then your radiation oncologist will typically see you once a week just to check in with you, make sure you're feeling okay, doing okay, answer questions.
That's a great explanation. I feel like that would be so helpful to have known and to really understand all of the people behind the scenes helping out, which I think is really great to know that everything's really looked at by a number of people while they're putting it together. And also to understand that the doctor won't be there, but these technicians are, or therapists are really skilled in planning this. And I think one of the things that always amazed me was, even if the appointment was 45 minutes, the radiation itself, as you said, can be 2 minutes. It's all the positioning and the working out the spacing. And so, it's normally just getting someone comfortable on that bed and then doing it. So I think that's an important thing to realize is that the radiation itself is quick. Um, Dr. Yang, what about side effects? So, what are some of the short-term side effects people can expect, and when can they expect to start feeling those side effects?
Yeah, so I'm going to focus on the brain because that's the most common site of treatment for radiation for leptomeningeal metastasis. And it's the primary driver of side effects in a lot of ways. And again, I'm going to focus on the more short term. So the typical either it's whole brain radiation or craniospinal radiation. The typical course of treatment is 2 weeks. It's once a day for 10 treatments. So 10 business days, so to speak. Um, Typically, I educate and discuss with my patients that some of the more common side effect to be expected is fatigue. And that can start around the second week of radiation and can last up to a month even after radiation is complete. Typically not to the point that a patient cannot get out of bed, but more so some patient may want to take a nap in the afternoon, which is perfectly okay.
Mhm.
I do make all my patients walk every day. I think making sure that not settling into this sedentary lifestyle, it's really important. The more active you are, and there's tons and tons of great research on this, the more active you are during the radiation treatment, the less tired you will be. I know it's a little bit intuitive, but we do see this in our patients. The second most common side effect is hair loss, and this is temporarily. Typically, it usually happens after radiation is done, after 2 weeks radiation is done, and can take up to 4 to 6 months for the hair to come back. And that also depends on what systemic therapy the patients are receiving. Obviously, if they're on chemotherapy, that also impact hair loss. That period of time will be longer. But the most important side effect I definitely make my patient tell me religiously and and as they should, is any kind of neurologic symptoms, any headache, nausea, vomiting, vision changes, hearing changes, anything that is unusual to them, or that they have had these symptoms and they have gotten worse during the treatment. I always want to know right away. Reason being that as the tumor cells are dying or throughout the treatment, um, our body naturally react by generating this immune response. And that can translate into a lot of these kind of neurologic symptoms that from the inflammation or the immunologic response that is happening. And the way I think about it is that this will happen. This is how our body reacts. But we're walking this fine line between letting it happen, but not so much that it overwhelms the system, and that makes you extremely uncomfortable and not be able to tolerate the treatment. So the earlier we know about them, the sooner and the quicker we can help with these symptoms and so we can continue the treatment safely. I noticed that in younger patients, there seems to be an earlier wave of this inflammation. In older patients, the inflammatory symptoms tend to happen later on during the treatment. It is not entirely predictable, but it can happen at different time points throughout the treatment course, and the more that you let your physician know or their teams know, the easier it is for them to help you manage these symptoms.
So when you say throughout the time course of the treatment, does that mean that you wouldn't see these types of symptoms from radiation a week, a month later? Like they wouldn't start later after treatment ends? That wouldn't be radiation
Yeah, so
fatigue?
that's a good question as well. So typically these symptoms happen during the treatment course or shortly after. If if you're presenting with headaches, that's waking up in the middle of the night, 2 to 3 months after the treatment. I worry there's something else that's going on. And we can dive into more details on those, which could be a wide range of things that could happen. One is, whether if there's intracranial pressure that's being elevated or there's disease that's irritating specific parts of the brain. Um, and these symptoms that happen later will often they're sort of a red flags for me that I need to do some investigation right away to figure out what's going on.
That makes sense. One more question for you, and then I'll switch back to Dr. Hadagan-Gluth. What about, can you do anything to prevent these? Like, can you do anything before treatment or during treatment to prevent some of the side effects? I know you said walking is really good, but are there other things people can do?
Yeah, so quite often it depends from the people's practice can be different from place to places. Quite often I would talk to my patients about having some low dose steroid on board, for example, if I suspect that the patient's going to have a harder time with the inflammatory response that may happen. Steroid it's a really powerful tool to reduce inflammation. We use it sparingly, but when we need it, we need it. I think that's something that as a radiation oncologist, I'm sure Dr. Hadengai felt the same way, that this is a tool in our pocket if we need to use it either preventatively or to treat the symptom that's happening. We quite often use that. Other things that I use in my practice, there's some evidence of this herbal medication called boswellia that can help reduce swelling in the brain. Um, when it's given with radiation, I quite often use that nowadays to try to preventatively reduce any type of swelling that happens. And there's a medication called memantine. This is more tie into the later effect. Um, which can also reduce the risk of any kind of short-term memory issues that's related to treatment as well.
Perfect tie-in. Thank you to Dr. Hadangari Gluth. I was just going to ask about long-term side effects like cognitive issues or memory loss. And I know Dr. Yang started talking about that with memantine. Can you explain a little bit more what people can expect and how long that would happen or when it starts?
Sure. It's important to remember that patients with leptomeningeal cancer may have memory changes or cognitive changes at the beginning of that journey. So they may have some of these changes, unfortunately, from the tumor itself, from swelling, as Dr. Yang was explaining, from systemic therapy and chemotherapies that they've had, from elevated pressure in the brain. Or in the tumor itself. So there's a lot of it's hard to say, exactly how each patient is going to react as they kind of start from a different place. But typically, the effects, particularly when we're talking about long term, the one that's probably the most feared and also talked about and sort of assigned to radiotherapy is the effect of these therapies, particularly from treating the brain, on long-term cognitive function, and that can manifest in different ways. So long-term effects can happen anywhere from 6 weeks to 6 months to a year later and beyond. And typically it depends, also on how long our patients are going to live. And it's sometimes hard for the treating physician to give the patient an exact idea of when to expect some of these things. But typically we say a few months are what we talk about long-term effects. And the long-term effects, particularly on how thinking function, could depend on and depends a lot on where they started, their age, how their thinking is at the beginning, and then also on how much of the brain is treated. So when we're treating with really focal treatments, and let's say it's a really small brain metastasis, typically the long-term cognitive effects are pretty negligible. If we're treating the whole brain, there could be more of those cognitive changes to expect, and that can manifest in different ways. Things like short-term memory, multitasking, executive functioning, planning, things like that. Typically, patients, they're not going to forget, their names or their family, their spouse's name, their children's name. They're not going to forget long-term memories, but some of the short-term memories are harder to retain, and word finding issues are common. And so patients may want to try and write things down or have somebody with them, or kind of come up with maybe lifestyle changes that could help with that. There is also a medication, as Dr. Yang explained, memantine, which is a generic medication that was used in vascular dementia that was sort of repurposed in a clinical trial to sort of help mitigate some of that cognitive change that we see particularly after treating with the whole brain. And so we typically don't use that medication if a patient's getting radiosurgery, which is the focus treatment, but we can use it when we're treating larger volumes, like in the context of craniospinal radiation, which you're still treating the whole brain, or whole brain radiotherapy. And that medication's typically given for about 6 months, but sometimes patients can take it longer. And you typically start that medication during radiation and then continue it. Other long-term side effects, sometimes the fatigue can sort of linger, but fatigue is a complex one because patients with leptomeningeal cancer are also getting lots of other treatments that may be making them tired. The disease itself could also be making them tired. Things like headaches could happen. And typically when we're treating the spine, certain areas of the spine, sometimes we might see skin changes. Those can get better, but typically those are more short term, so that should be really getting better by the long term when we say months. Also, hair loss is something that patients, when you're treating the whole brain, can get hair loss, and that is from the radiation. That's typically seen more of like a short term side effect, and it typically will grow back by 6 months to a year. It may not grow back exactly the way it was before, but that typically does grow back to some degree. So that's also not really a long-term side effect as much. And then there's also a risk long term that radiation itself can cause like a little bit of almost like a little bit of scarring in the brain that you can pick up on an MRI. Sometimes the patients won't even have any symptoms from it, but when we're looking at the MRI, we'll look at it in detail, and sometimes we'll see a little bit of area where the contrast is being released when they give you the IV contrast, and that, or maybe some inflammation, and that'll indicate, as Dr. Yang was explaining, there could be kind of a little bit of a reaction there, some inflammation, or almost like a little bit of scarring. And sometimes it's really just radiographic, which just means it's on the MRI. You wouldn't see it by looking at the patient, but you'd only know by looking at the MRI. And sometimes, a lot of the time, it doesn't even have any symptoms in the patient. The patient wouldn't even know it's happening. But it's something we can keep an eye on with the MRIs. Sometimes that inflammation can cause symptoms, so that sometimes patients can have headaches or some other symptom, like Dr. Yang was describing. And in those cases, we typically would use some medications potentially to help bring down that inflammation. So things like boswellia, which is just Indian frankincense. So it's it's not FDA approved, but it's been used for lots of anti-inflammatory purposes. It's kind of available over the counter as an herbal supplement. Steroids, corticosteroids, which are very commonly used but can have side effects when used for a long period of time. Or even potentially infusions that help with bringing down that swelling, that are things like bevacizumab, which is a VEGF inhibitor, so kind of works by robbing the area of the ability to make new blood vessels, so it can help bring down the inflammation in the brain or even sometimes in the spine.
So, one of the questions we did get was how you can tell the difference between radiation necrosis and active brain tumor. Is that something that's easy to do if you can read the MRI, or can it be confused for one another?
It's definitely probably one of the most, holy grail of questions that plagues any clinician who's taking care of brain and spine tumor patients. It's a very common thing that happens where we're trying to decide whether this particular imaging change is radiation changes. I don't like to use the word radiation necrosis because patients are typically getting a lot of other therapies. So the necrosis or treatment change could be from their systemic therapy, their radiation therapy, surgery, intrathecal therapy. It's from a lot of things. So these treatment changes, as I like to call them, can be hard to distinguish from tumor, and it depends on the center that you're at, if they have the expertise to evaluate the MRI. So it's also the acquisition of different sequences during the MRI. So typically we get at our institution, in addition to the sort of standard post contrast and T2 FLAIR images, we get other images like perfusion, which is like a blood flow map to show whether there's elevated blood flow, there's diffusion, there's PET sequences. So there's a lot of other imaging tools that clinicians have at their disposal to look and better query an area of the brain to better understand whether something is tumor or treatment change. Typically, if it's treatment change, we'd want to leave it alone, right? You don't want to treat it again. But if it's tumor, an active tumor, and it's growing, typically the patient will, the physician and patient will talk about potentially changing therapy or doing something in addition to treat that area. But it is challenging to distinguish, but not impossible. The only way to know for sure would be to biopsy it, which is invasive, and that typically involves, meeting with a neurosurgeon about actually biopsying that area of the brain, and it kind of depends on where that is.
Yeah, it's just a very common question we get, and I'm sure you get it all the time. Is this disease progression? Is this tumor growing? Is this radiation side effects? And how do I tell? And so I think, that's just something, obviously, it's a complicated question for everybody. Dr. Yang, so when would you start seeing improvement in your symptoms from radiation treatment? Do you feel like it's immediate? Maybe like the headaches, like you said, could be relieved quickly, or does it take a while to see that improvement? Because we often hear from people who say, I don't feel like I'm getting better. I almost feel like I'm getting worse. What can you tell those people?
Yeah, and to be honest, I think it's a complicated question with not a straightforward answer. And Dr. Hadengard can weigh in as well. I think the Probably the way that I approach this is that I think we have to set realistic expectation at the time of consultation of what we're trying to achieve. In general, I educate patients that your symptom can get worse before it gets better because of the inflammation that may happen with the treatment. But the main goal of the treatment is to make sure that we stabilize your symptoms and that we may not see a significant improvement in your symptom. When we do, we're very happy about it. And the truth is that we do see improvement in symptoms in a lot of our patients. But going into the treatment, I think more realistically, we have to understand that the reason for the treatment is to make sure that your symptoms don't keep getting worse for the long run. And I think that's a little bit harder for a lot of people to understand because if you have a cold, let's say you start antibiotics for a bacterial infection, it gets better and you feel better. Neurologic symptom isn't exactly the same way. And a lot of times I see patients with a lot of symptoms, hoping that after the treatment that these symptoms will resolve. And I have to set the expectation that, we're really hoping that you don't develop more symptoms with this treatment. Um, I know it's not a direct way to answer your question. When do you see symptom improvement? The truth is, I think that um, every patient is a little bit different in that regard. But the goal or the aim of the treatment is to making sure that we don't see worsening of your symptoms. And this is why, at least in my practice, I try to push the treatment as early as possible, because once a neurologic deficit or neurologic symptom sets in, it is very hard to reverse them if they are reversible at all. So what we should aim to do is really try to prevent symptoms from developing, and that's why again in my own practice I set that expectation and I try to intervene as early as possible. I'd be interested to hear what Dr. Haringarigu would say.
Yeah, I was going to ask, do you have something do you want to add or?
I mean, I agree. I think Dr. Yang was like, I mean, I agree with him. I think you have to sort of set goals, sometimes depending on what the symptom is. Like, for example, I've had patients with leptomeningeal cancer who had a lot of symptoms from just the elevated pressure in the brain, and starting something as quick as whole brain radiation, bringing down that pressure was a huge symptom relief. Sometimes it's hard to confuse. Can get confusing because some symptoms can get better, but then some of the side effects, like we talked about, could get worse. So they're happening at the same time, and it's hard to discern what's getting better or what's getting worse. Sometimes the patient, you're kind of getting the fatigue and the side effects at the same time you're delivering the treatment. So I tell patients to sort of wait to see what the benefit's going to be, and not to, you always want to meet with your doctor and talk about, and that's why we'll see you every week, because we don't want you to abort treatment after a few treatments because it's making you feel ill and you're not seeing the treatment benefits yet, because sometimes those benefits may not be seen until you get the MRI a month later or 6 weeks later. So it can kind of really depend.
Yeah, and Dr. Yang had mentioned about the sequencing of treatment just in terms of starting as soon as possible. Do you agree with that as well, Dr. Haringad? Because that comes up a lot too. Do we do it ASAP? Is it before or after treatment? Should we do it at the same time? Because people feel, this urgent need to get treatment.
You mean which therapy you're doing together with?
Yeah, and really, is it something that you sequence like radiation first, or does it come throughout the other
Yeah.
treatment?
Yeah, I mean it's hard, again, it's like
I
hard to,
know.
we don't have like ideal workflows. I think that's something that we're trying to do as Dr. Yang's really a leader in this field in leptomeningeal cancer, and working with him and other people across the country who are experts in kind of saying, is there a workflow for when a patient presents, which of these modalities should we start first, how should we order them, Because sometimes it's really the clinician just trying to working with their colleagues, trying to make the best decision for that patient, what's available there, we could start quickly. And yeah, and I think he's right. We don't want to overlap everything at the same time and then make patients really ill, but we also don't want to wait a long time between to each thing. But typically, when we're delivering radiation, we don't really want to do other things at the same time. So, meaning we're not giving, typically for leptomeningeal cancer, we're not giving concurrent systemic therapy or infusional therapy or oral chemotherapy or, intrathecal therapy. Typically, we aren't, unless it's done, perhaps on a clinical trial or something like that, or there's some compelling reason that the clinician wants to do it that way.
So, one more question for you before I move back to Dr. Yang. What about receiving repeat radiation? Can you receive repeat? Does it matter if it's proton one time and photon another? Does it matter where it is or what type?
Yeah, that's a really good question. It really kind of matters more. There's a lot of questions, a lot of potential nuances to that answer. It all depends. When we're doing really focused radiation, like radiosurgery, let's say in the setting of a brain metastasis, but then 2 years later, the patient develops leptomeningeal cancer and we need to treat, the whole brain and spine, for example, then absolutely it's okay to do that. Typically the overlap consideration of how, when was the previous course of radiation, how much did they give, what did they treat, where it was, all of that will be evaluated by the radiation oncologist who's making the decision. And they typically want to see those prior treatment plans, where the dose went and how much it was, and when it happened. The longer the interval between the first treatment and the second, or even the third, the more we understand that there's probably going to be some repair of those normal tissues, so we're able to give give an additional course. So it really sort of depends, and it doesn't. If a patient has had prior photon radiation and then now, let's say proton in CSI is indicated and that's available for them, it doesn't matter if they had photon before, and we're doing proton now or photon now. That doesn't really matter. It's more where the dose went, how much was treated, and what the interval was. One area that we're particularly probably very cautious on is the spine and the spinal cord, because radiation can cause injury to the spinal cord if more than a certain amount is given. So we are particularly careful, for example, if the patient's had prior spine radiation, in retreating the same area of the spine to a particular dose. So all that will be evaluated by the treating physician.
That actually was the question that came in. Was it okay to do full spine radiation twice? So I think that answered that.
Yeah, I mean, again, it sort of depends. I mean, typically we don't do craniospinal again. Dr. Yang's really the expert on this, so I'd let him take that one. But typically we don't do a whole course of craniospinal and then a few months later do another course. That's a pretty once in their core treatment course. But sometimes we would do craniospinal, for example, and then there's like a focused area of the spine, maybe at the bottom of the spine, that needs some treatment. We could come in there, or there's a focused brain metastasis and we could treat that more focused. So we really like to combine sometimes bigger and then smaller treatments where appropriate. But yeah, we're typically not doing whole spine and then treating again whole spine.
That makes sense. Dr. Yang, did you want to add anything or does that cover it?
No, I mean, I think that definitely covers it. I think also one thing that patient may not realize is that when they receive radiation for other sites of the body, quite often that also contribute radiation to the spinal cord, for example. So we have to take that into account. For example, if you had lung cancer treatment before that require radiation, that it's definitely a part of the equation when we decide what type of treatment you should receive, and that would be safe and at the same time efficacious. It's not just specifically that we treated that area before, but other sites of the body that receive radiation could also contribute to the same area.
Yeah, that's really good to know. I don't know if everybody is aware of that. And I think it's really important because so many people have already been treated for their cancer and they may have had radiation as part of their primary cancer treatment. I don't know who can answer this, but I'm going to throw it out to both of you. We do have a lot of people outside of the United States and always asking about what's available in Europe and what's available in Australia. And, can we say anything about treatments there? Do either of you have any thoughts there that we can add or?
I think I can start. I also want to put a plug for Dr. Hadangadi Glue, who is going to be a keynote speaker in one of the European conferences coming up, so she may have more input on that. I think, it's very interesting as and Helene, because you've been part of our group for this past year, for example, during our think tank. Um, yeah, the practice between the U.S. and Europe for leptomeningeal metastasis it varies quite widely. Um, and For example, I think in the U.S. More and more people are doing craniospinal radiation, given the data that was generated here in the U.S. But that trend has not yet caught on in the European countries. Um, I think I see in my own practice, I see quite a bit of patients coming from Europe seeking opinions and potential treatments. And I do see I do see the difference in approaches. And not saying that one approach is better than the other. I think that we're all just working with different constraints of our healthcare system, all the physicians have to use the tools that they have in their toolbox to best take care of their patients, and they may be different from places to places.
That makes sense. Okay, we have about 5 minutes. I wanted to see if either of you wanted to share any update on current clinical trials or where the field is headed in terms of radiation therapy that might be helpful for people to hear about, or any ones that are available for people to enroll in. Dr. Haddon, yeah, do
Yeah,
would
I
you like
mean,
to
I
start?
I guess I'd want to start maybe with a shameless plug for a tool that was created and helped by Dr. Yang and Helene called, and it's a web-based free tool that you can use on your phone or your tablet or your computer. And I believe it's linked on, Helene, your website as well, the foundation website. It's called Lepto Trials. It'll be presented at the SNO-ASCO brain metastasis, CNS metastasis meeting in the fall as well. And essentially, it'll just query clinicaltrials.gov for the patient. So you can just you can input your age, your tumor type, any other factors that you want, and it'll pull up for you in real time open and accruing trials and what the trial is and the primary contact from clinicaltrials.gov, which is really the centralized resource for most clinical trials. I will add, just piggybacking on what Dr. Yang said about Europe, is that it's actually quite well represented from Chinese trials and the United States. I don't know that the European trials that are only open in certain European countries always input their trial data on clinicaltrials.gov. So I think if you're looking specifically in Europe, it may not be as there are still hits. You'll still find some results. Kind of depends on where you live or where you're looking. And then another shameless plug for Dr. Yang's clinical trial, which is a phase 3 trial of involved field versus proton craniospinal radiation, which is enrolling. That we're all of us very, very excited about. We really want to keep enrolling on this trial because I think it's been one of the only therapies really in radiation therapy that have really transformed the management of this disease. So as much as possible, trying to seek out trial opportunities, where available to contact as well about trials, as particularly for Dr. Yang's trial as well. Most clinical providers in radiation oncology would know about this trial because it is open through the NRG, which is a huge cancer cooperative group. So it should be more readily available than a single institution trial.
Excellent. Dr. Yang, do you want to add anything?
No, I mean that was very kind. And I will also put in a shameless plug for this tool that's going to be available for you. I think it's where Dr. Haringadi did mention is that her son developed this tool, which is just beyond. I am like I wish I have half of the talent of her son. And this is such an important tool for us as clinician and for patients to have that access. I am sure that many of you have struggled with using the clinicaltrial.gov website. I will just let you know that struggle is real. Even for us who speaks the language, it is very difficult to use for leptomeningeal metastasis, and this tool really simplifies that.
I absolutely agree. And it really helps to have it for our website and to link to it because right now I manually go through and add trials, which is not the best practice, but it's the only way that I was getting everything on our website and really filtering out ones that don't accept patients with leptomeningeal disease. It's really hard to find that. So I am thrilled that we have this new tool for everybody to use. So, did you want to say one more thing,
Oh,
Dr.
yeah, I
Hadi?
was just going to add to that. I think one of the reasons why it's really important is because, and your advocacy is really important for us as clinicians, is that we too, are frustrated by patients with leptomeningeal cancer being excluded from clinical trials, and that's typically been the practice. So it's nice to have a tool and a foundation that's really focused on you, right? So this is like for you. So patients who don't have leptomeningeal cancer wouldn't be eligible. So it's really a trial resource and trials like Dr. Yang's that are really going to hopefully encourage physicians and encourage trialists really to develop more trials like Dr. Yang's trial really for patients for this patient population.
Absolutely. And include more patients with leptomeningeal disease in their current trials that are being excluded at this
Exactly.
point. Well, thank you both so much. I think this was really helpful, a great conversation. We will make sure to get this up on our website so everybody has access to it. I will make sure that the leptotrials.com website is shared again so everybody knows where to go for that. And we just want to say thank you to our panelists, to our producer, and to all of you for joining us today. And be sure to follow us on social media and sign up for our newsletter because that's where we'll announce all of our upcoming webinars and all of our current information as well as current clinical trials. So thank you all and have a lovely day.